Hello and welcome everyone. I'm Dr. Dalia Tsimpida and I'm passionate about research that transforms the lives of people with hearing difficulties. Today we celebrate the World Hearing Day, a day that is important for more than 460 million people with hearing loss around the world and for those with whom they communicate. I'm going to talk to you about an important part of our lives. I'm going to talk to you about hearing. And hearing is important because hearing connects us. We humans are made for relationship, and hearing, for those not born deaf and fluent in sign language, is central to the sharing of emotions and ideas and happenings. When somebody loses their hearing, not only the ear function itself is affected, but also related activities. For example, understanding speech during communication is reduced, and participation of the individual in society is affected. The employment opportunities are limited, and there are many barriers in education, in attending social events, or receiving health services. So if we want to improve the hearing health of the population, we need first to assess, measure, and understand all these complex phenomena. Because if we can't measure something, then we can't manage and improve it. This perspective will inform my presentation, which has the title, You Can't Improve What You Don't Measure. I'm going to cover three topics aiming to answer these three major questions. How big is the problem of hearing loss? Why do socioeconomic and lifestyle factors matter? And why is hearing loss an important public health issue? Hearing loss is a major public health issue estimated to affect over 11 million people across the UK, which translates to 1 in 6 people. By 2035, it is estimated that there will be more than 15 million people with hearing loss in the UK, a fifth of the population. I've said 9 million. There is no screening program. So how is that being calculated? To date, the prevalence estimates of hearing loss in England are calculated using data from a study by Davis, who collected and analyzed audiological data in the 1980s. Despite its importance to the history of hearing care in the UK, Davis' study had some significant limitations. First, the prevalence estimates are based on a sample of only 2,578 participants. According to the hearing problems of that sample, a percentage of hearing loss was calculated for each age group that participated in the study. For example, 18.9% of those 51 to 60 years old had hearing loss of over 25 decibel hearing level. Today, each clinical commissioning group, who is responsible for an area in the UK, uses the population demographics to estimate the number of people with hearing loss in their area. For example, the population demographics show that in 2015, in central Manchester, there were 14,000 people aged 51 to 60 years old. Therefore, according to the percentage of the Davis study, it is estimated that 2,720 of them may have hearing loss. However, this audiological data was collected and analyzed in the 1980s, and this data's accuracy has not been validated in the last 40 years. But importantly, calculations calculating the local hearing health needs through this audiological data, we assume that the percentage of those with hearing loss will remain the same, no matter the place that people of the same age live. However, this does not reflect the reality, because where people live plays an important role in their health, as the location shapes several environmental risks. In Davis' study, the English samples were derived from only 2 cities. As you can see, Nottingham and Southampton. So the samples are very unlikely to be representative of the whole population in England. In other words, that study did not consider in its estimation the effect of place and socioeconomic factors such as high occupational noise exposure from manual occupations and differences in regions of England with strong and weak manufacturing industries. Where people live significantly affects their health outcomes. If it didn't, and only age was responsible for the loss of hearing as we grow, we would expect that the prevalence of hearing loss in people of the same age would be the same no matter where they live. In order to test that assumption, I analyzed all the available hearing data in the English Longitudinal Study of Aging, or ELSA. Due to the sampling method, the participants in ELSA have similar mean age profiles over time, as the study is a representative study of the English older population, aged 50 years old and above. The number of people with hearing loss increased by 10% over 15 years. However, the mean age of the people I analyzed stayed the same. You can easily look at the different colors that represent the differences in hearing loss prevalence derived from people that have similar age profiles in each region and in each year of collection. Over the same period, the samples had markedly different hearing outcomes in terms of where respondents lived, and the increased rate of hearing loss ranged from 3.2% to 45% between different regions of England. Remember that these representative samples were from people with similar age profiles. The results provided surprising evidence that the increasing trend in hearing loss prevalence was not age-related, as widely believed, but is potentially due to social and lifestyle changes. This is a significant milestone in hearing loss research and a breakthrough that gives us considerable insight into what is actually happening. These findings have important implications for health policy and planning for health services in England and globally that should be based on the actual needs of the populations and not on the age of the populations through projections. Science is about admitting what we don't know. And a natural next step was the PLACE project, which will provide a significant opportunity to validate the existing audiological data after nearly 40 years. I chose the title of the project to give also a symbolic meaning, as the word place represents the geographic context and the role a location plays in people's lives. The study will utilize data from the 7th wave of the English Longitudinal Study of Aging, which contains objective hearing data from 8,529 participants aged 50 to 89 years old that gave consent to have their hearing acuity measured. Aim will be to explore regional patterns and identify potential regional differences in the current prevalence estimates of hearing loss in England. Now I will explain why a socio-spatial approach is crucial for planning sustainable models of hearing care. The unequal distribution of power, money, and resources in society leads to social inequalities. As a result, some groups of people are more privileged than others, which creates injustice and disadvantage that influences life experiences and health outcomes. Some critical indicators of socioeconomic position include educational status, occupation, and income. Hearing health inequalities is an emerging research area, and I and my colleagues recently proposed a definition saying that hearing health inequalities are the avoidable differences in people's hearing health across different social and population groups. The mechanisms by which these inequalities are generated remain unclear. So during my doctoral studies, I developed the first theoretical framework which adopts a life course epidemiological approach in understanding the modifiable lifestyle risk factors for hearing loss. Let's now look at this novel model that depicts the modifiable determinants of hearing loss in several stages across the life course. First, children born to parents from a lower socioeconomic background tend to experience more illness and injuries, and the antibiotic drugs used may affect hearing health, especially in sick babies with a genetic predisposition. In turn, consequences of hearing loss in children can include impairment in language skills and lower educational achievement compared to children with normal hearing. The lower educational status is also related to the lower health literacy, which is a common issue among people of a lower socioeconomic position. That can explain why individuals of a lower socioeconomic position adopt an unhealthy lifestyle with higher levels of smoking and alcohol consumption, higher body mass index, and lower levels of physical activity, which are all risk factors for hearing loss. The lower educational level is a predictor of social inequality in later life, as it limits employment opportunities, relegating them to more poorly paid jobs. Furthermore, low-level manual jobs are those with a higher level of occupational noise, which is a risk factor for hearing loss. Occupation and income then may affect access to hearing health services and hearing aids use due to the financial barriers that affect the help-seeking behavior for hearing loss. These hearing health inequalities can affect the retirement status and income of older adults as they affect the ability to continue working or to advance occupationally. Also, hearing loss affects communication in healthcare settings and so affects the quality of care and management of other health conditions that are commonly comorbid with hearing loss. As hearing health deteriorates, this lowers socioeconomic status further and results in a worsening cumulative hearing health over the life course. Tackling socioeconomic inequalities in hearing health during the life course could significantly improve the hearing health of populations. The hearing health inequalities model aspires to be used as a novel tool for prevention, identification, and management of hearing health inequalities and for policy formulation aimed at hearing loss risk reduction. To verify the role of socioeconomic and lifestyle factors, I and my colleagues presented the first study in audiology that examined the association of objectively measured hearing loss with 4 different socioeconomic position indicators: education, occupation, income, and wealth, and several modifiable lifestyle factors such as tobacco consumption, body mass index, physical inactivity, and alcohol consumption above the low risk level guidelines. We found that those in a lower socioeconomic position were up to 2 times more likely to have hearing loss. The adjusted odds of hearing loss were higher for those with no qualifications versus those with a degree or in higher education, those in routine and manual occupations versus those in managerial and professional occupations, and those in the lowest versus the highest income and wealth quintiles. The study showed that hearing loss among older adults is as strongly associated with socioeconomic and lifestyle factors as with core demographic risk factors such as age and gender. In simple words, age was not the most important risk factor for what is widely known as age-related hearing loss. Instead, several preventable factors are involved to a large extent in the pathways of the association between socioeconomic position and hearing loss. These findings are supportive of a new conceptualization of hearing loss, which argues that hearing loss is not necessarily an inevitable accompaniment of aging, but a potential preventable lifestyle disease as linked to environment and lifestyle. The term age-related hearing loss is not an inclusive term, and we cannot express, using this term, the many hearing problems without specific etiology in older age. So we propose to the scientific community a new term, lifestyle-related hearing loss, where lifestyle refers to social practices and ways of living adopted by individuals that reflect personal, group, and socioeconomic identities. Of course, lifestyle choices are influenced by the social, economic, and environmental conditions where you live. However, 50% of cases of hearing loss are due to preventable causes, and people can play their part in making decisions in everyday life concerning hearing loss prevention that will help them to maintain or improve the quality of life during the life course. Hearing loss is an important public health issue. Let's now see why. Hearing loss is far beyond a sensory impairment because hearing loss has many physical, social, cognitive, economic, and emotional consequences and affects the quality of life. It is the third most common chronic health condition after high blood pressure and arthritis, the first leading cause of morbidity among adults 70 years old and above, and the second leading cause among adults 50 to 69 years old. In a recent study, I and my colleagues found that up to a third of older adults with hearing loss in England could be undetected and untreated. The study, published by JAMA Network Open, might mean millions of people are not seeing ear specialists or given hearing aids when their hearing has considerably deteriorated. This lack of self-awareness of hearing loss is a problem for many people. It is crucial that those with hearing loss are detected in a timely way, referred to ear specialists, and given access to hearing aids. The early identification of hearing difficulties in primary care may be the key to tackling this major public health issue. But why do so many people fail to realize that they have a decrease in their hearing? The reason is that many people believe that hearing loss refers only to the inability to hear sounds in terms of the intensity of a sound. However, hearing loss refers not only to the intensity of a sound, the loudness of a sound in decibels, but also to the frequency of the sound in hertz. The range of sounds of the average human speech can be represented in a banana-shaped region known as the speech banana. When you have a hearing loss of certain frequencies, it is harder to detect yourself because the frequencies unaffected appear pure and clear. This may lead you to the impression that your hearing is completely normal, which may lead to a wrong self-diagnosis. And as hearing loss develops gradually, people don't see it as a dramatic health problem requiring urgent intervention. And they persevere with declining hearing for approximately 10 years before they seek help and take up a hearing aid. There is not a national screening program, and those who are diagnosed are usually diagnosed by their own doctor. But if the patient doesn't bring the matter up, the doctor might not ask about it. More research is needed to understand why so many people are undiagnosed, though I and my colleagues feel that making hearing loss part of a routine primary care examination among older adults will be beneficial. The early detection of a decrease in hearing is important because hearing loss affects the whole quality of healthcare and patient safety. People with a hearing loss often find it really difficult to communicate with health providers, and very often they are left unclear about the condition and the medical instructions after an appointment. This is what deaf or hard of hearing people feel when hearing people speak to them. It is hard work. It is really hard work, and this is crucial not only for the patient, but also for the healthcare professional, so as to be able to communicate with the patient with hearing loss about symptoms of a health condition and to do an accurate diagnosis. So it was not surprising that in another study, I found that almost all deaf and hard of hearing people were dissatisfied with the way health providers communicate with them and didn't have trust or confidence in the health professionals. The problems with communication are also associated with poor adherence to medical treatment, which poses a significant risk in patient safety, especially in polypharmacy. This also has a huge economic impact because National Health Service and social care services weighs approximately 150 million pounds annually by not making primary healthcare services accessible for people with hearing loss. 14 million per year because of missed appointments, 76 million per year in extra GP visits, and 16 million per year in increased use of social care. Hearing may also be a driver of other health problems, for example, depression. In my recent study, I found that those with a hearing loss had 40 to 58% higher risk of having depression. Importantly, a graded relationship between hearing loss and depression, according to socioeconomic position, was revealed, with those with hearing loss in the lowest wealth groups experiencing up to double the relative risk of depression compared with those in the highest wealth quintile. As you can see in the slide, hearing loss is linked not only with depression, but may also be a signal of cardiovascular disease, Alzheimer's and dementia, diabetes, chronic kidney disease. It is tied to threefold risk of falling, 32% increased hospitalization, and greater risk of mortality. Many of the mechanisms that explain the link of hearing loss with all these health conditions are still unknown. However, just take a moment to think how difficult it may be for a person with a hearing loss to communicate with the health professionals and manage these chronic health conditions in parallel with hearing loss. So it is important to understand the magnitude of the problem in England and globally, as hearing loss affects the functional ability that enables well-being in older age. Recently, aging and hearing health sectors joined forces to raise awareness of the link between hearing and healthy aging, and the importance of improving access to hearing care for older adults. The WHO World Report on Hearing, which is launched today, emphasizes that the functional ability of older adults is not maximized unless individuals have good hearing. The report highlights that it is possible to have good hearing across the life course through integrated, people-centered ear and hearing care. This position aligns with the UN Decade of Healthy Aging, which aims to maximize the functional abilities of older people through the delivery of person-centered, integrated health and social care within age-friendly environments. The vision is to have a world in which no person experiences hearing loss due to preventable causes, and those with unavoidable hearing loss can achieve their full potential through appropriate interventions, education, and empowerment. A recent paper estimated the global costs of hearing loss and concluded that the annual global cost of unaddressed hearing loss exceeded $900 billion, and that the 5% reduction in prevalence of hearing loss would reduce global costs by $49 billion per year. The time is now to make hearing health a public health priority, and most importantly, to let people enjoy healthier lives. Healthy aging can not only add years to life, but it adds life to years, and hearing plays a major role in that. Remember, in order to improve people's hearing health, and consequently their overall health, we need first to measure how many people have hearing loss. In this lecture, I try to give answers to three major questions. How big is the problem of hearing loss? Why socioeconomic and lifestyle factors matter? And why hearing loss is an important public health issue. Thank you very much for being with us today. I'm sure you will now have realized how important hearing is for our lives, as it lets us enjoy life and connect to the world. Thank you very much.